So hello everyone, thank you for attending the CSF Educational Lecture down in North Carolina. I want to thank Dr. Allison Ashley Cook for helping us get the facility for this evening. My name is Kathy Posnick and I am the chapter coordinator for the Chiari and Syringomyelia Foundation. I live near Cleveland, Ohio, and with my husband Jim and 3 boys, and I do have 2 boys with these medical issues. And we've been dealing with these issues for over 13 years with lots of ups and downs. Wanted to tell you just a little bit about CSF and what we're doing. We're very excited. We commend our boards for having the vision to see that we can unlock so many answers by expanding the scope of our focus. It is estimated that 350,000 Americans have Chiari malformation and or Syringomyelia, and when we begin to speak of the related disorders, the numbers go into the millions. To help hold CSF to these standards, we work hard to maintain these seals of approval from reputable organizations. You'll see the BBB. The first is the BBB Charity Accountability Seal of Approval. They have a rigorous 22 standards that you have to meet by providing documentation that includes information on how CSF is governed, the ways in which we spend the donations you provide, the truthfulness of our representations, and in our willingness and ability to disclose basic information and financials to the public. The GuideStar is we update our nonprofit report on GuideStar.org annually, and we have attained the Gold GuideStar Exchange member level. And very recently, we've been approved for the HON code, which is the Health on the Net code. We applied back in January of 2013. It took us 19 months to hear back from them. And we got it. And we're very excited. So our website is now considered a verified source of accurate and responsible health information concerning these disorders. This just further validates CSF's commitment to providing accurate information to patients and medical professionals alike. The research meetings and projects. We keep very busy hosting various research meetings and supporting research in the fields of Chiari, Syringomyelia, and related disorders. The meetings listed on the left are meetings we hosted for research this year alone. The right column shows you some of the research studies we have funded recently. 2 of the studies listed have already been published, and you can read about them on the CSF website under Research. The projects listed at the top are ongoing. Our chairman and executive director just met with the engineers at Georgia Tech who will be working to create a golf cart that allows children and adults living with paralysis to stay active and live healthy lives by becoming involved in golf. The International Patient Database is a huge project being worked on by upwards of 50 clinicians and scientists from approximately 10 different countries. This is a great step forward in the field of research because it will allow for research studies to be done with greater statistical accuracy. That accuracy will help us prove without any doubt what really does and does not work for people with these disorders. Collaboration with other organizations is a priority for CSF. We recognize that the ability and willingness to work alongside other entities is the only way real answers will be found for the individuals who struggle with these disorders. And that's why we are here, to find answers. CSF's focus includes Chiari, Syringomyelia, and related disorders. There are many related disorders, and they can include hydrocephalus, Ehlers-Danlos syndrome, scoliosis, connective tissue disorders, idiopathic intracranial hypertension, POTS, and dysautonomia, to just name a few. At CSF, we often hear medical professionals have never heard or vaguely heard of Chiari malformation. There tends to be a lot of frustration for people and their families who have these disorders. There are stories of people not being diagnosed for years. CSF created a campaign called Consider Chiari to help educate medical professionals about the symptoms and diagnosis of Chiari malformation. So how do we educate? CSF has been listening, and we are thrilled to announce that we are making a big push during 2014 to set up chapters all over the USA. I'm sorry, I just want to say this is the last slide for Consider Chiari, and we have these posters, and this was a group of nurses that Gretchen attended with, helped present there. And we were able to educate them about the Consider Chiari. And this is a campaign that we hope to grow over the next year or two. So okay, now going on to chapters. Sorry about that. So one of the jobs that the chapters will take on is the organization of educational lectures, the meet and greet, much like the meeting you are attending this evening. In addition, these lectures are always taped and posted on our website. It is a free resource and contains great information that can be viewed from anywhere in the world. We hope also to have the chapters not only help with setting up meetings like this, but also offer social and support activities, possibly be involved in the United Night Walk, and to help us move forward to help stop this pain. If you are interested in how to set up an ongoing chapter in your local area, please see me or call me, and I'd be happy to speak with you. United Night is one of the CSF's many annual events. It's a 1-mile casual evening walk in various locations around the country during the month of June that brings together people who are suffering with the devastating effects of Chiari, Syringomyelia, and related disorders. If you cannot participate in a group walk, there's always something called a solo walk, and they can fundraise with their close family and friends on their own. Solo and group walkers are all eligible for the same recognition prizes for meeting certain fundraising goals, and we love to give out those recognition prizes because they help spread awareness. United Night supports CSF chapters to provide education to physicians and the lay community alike. These walks also increase much needed awareness while funding important educational programs and research projects. Here are some of the pictures from last year's walk, and we were able to raise over $100,000. So very excited. The lower right was the Harlem Shake down in Orlando that we did. Lots of fun. Some of our other events are the Bobby Jones Classic golf outing, the Dinner Dance for Your Cure that I help put together where I live. We have the Night of Light Children's Gala coming up and the Charity Ball coming up. And you can read all about these events on our webpage. The newest branch of CSF's activities is our Unite at the Hill. Advocates, young and old, from around the U.S. came to Washington, D.C. to speak with their representatives about the issues that most concern people living with these disorders. 13 representatives' offices were able to have sit-down meetings with us, and we were able to personally deliver letters from advocates who had to remain at home. Several representatives had never even heard of these disorders, and they asked us to come back and continue to raise awareness and educate them more. And I wanted to thank you. That was all I wanted to tell you about CSF. There are some people that you guys might recognize because this was the North Carolina walk. At this time, I want to introduce Dr. Mankin. He is a board-certified, fellowship-trained pediatric orthopedic surgeon. After attending Harvard University, he received his MD from the University of Pittsburgh. He completed his orthopedic training at Harvard Medical School and his pediatric orthopedic fellowship at the Massachusetts General Hospital in Boston. He was on staff at the facility for 5 years before relocating to Raleigh, North Carolina in 2001. Dr. Mankin has experience and expertise in every aspect of pediatric care, from foot and hip deformities to fractures and sports injuries, including neuromuscular diseases like cerebral palsy. He has a particular focused interest in spinal conditions and scoliosis, spinal curvature. He has clinics dedicated to spine patients and has worked closely with local hospitals to institute a spinal rehab program for his operative and non-operative patients. He helped develop a pediatric core rehab program for children with spinal conditions. He also has co-hosted an annual spine camp to help and inform children with scoliosis and other spine conditions. He is the medical consultant for Back Talk, a patient-developed and operated support group of children with spinal conditions. At this time, I'd like to bring Dr. Mankin up, and he is going to give our talk tonight.
Well, thank you, everybody, for coming. I appreciate having to find this place. I had trouble with it. And to everyone in the future who's watching this in posterity, thank you for watching this. It's kind of weird speaking to the future selves, and I'll try to remember to include you. I am a pediatric orthopedist. I've always been interested in something that is not just the sort of typical pediatric orthopedist. I've never really wanted to stay confined in the box. One of the reasons I went into it is because I look at pediatrics of all kinds as a puzzle of sorts. And it's interesting how often when you look at the puzzle, Chiari comes up as the answer. It's not, I think, a coincidence that they used the crossword puzzle to do that. I became interested in the CSF, came to a meeting, was involved and was happy to be a sponsor of the Night at Night program, and very glad to be here. And this is also kind of a dream, because all the time when I give this talk about scoliosis, I say, well, there's a lot of different kinds of scoliosis. Here's the list of all the kinds of scoliosis that there are, but we're only going to talk about adolescent idiopathic, because really that's 90%, 95%. So the other stuff we'll touch on. Well, I finally get to not just touch on it, I finally get to really talk about it. So hopefully won't overwhelm you. And we'll see, we do get to Chiari eventually, but there are other things to cover. I do have a disclosure. I'm a speaker on the Speakers Bureau for Transgenomic, which makes ScoliScore genetic tests for scoliosis. I do touch on that, so I figured I'd better get that up front. So what do I mean by out of the garden? And I'm referring to garden variety. And that's an expression that is used, well, ultimately it started in horticulture, as you would expect, gardening. And what it means basically is what you would grow in your own garden if you just threw some seeds. So I go to the hardware store, I get cucumber seeds, and I throw them down, and that's what grows. Garden variety cucumbers, garden variety plants. It has a meaning of boring, ordinary. It probably doesn't necessarily mean that, because a lot of times it means safe. It's what you expect. You plant the radish, you get the radish. Not a Brussels sprout, to quote a song. So it's opposed to rare, unusual, or hybrid. And medicine co-opted that expression really early. We talk about garden variety appendicitis. We talk about garden variety gallbladder. We talk about garden variety scoliosis. I'll talk about that a lot, but we probably shouldn't, because all scoliosis is pretty complicated. But I don't want you to think that we're trashing scoliosis. It's a very important thing. But the interesting thing is to think that there are non-garden variety. There are the unusual. There are the rare. So this is the slide. Well, this is the garden. And we love the garden. The garden is perfect. It's beautiful. It's stately. It's serene. Everything is where we expect it to be. This is not my garden, by the way. I wish it was. But I planted that bush, and it grew as a bush, and I trim it back, and everything is perfect. So everything is safe there. There's a wall around it, a hedge. We know what's going on, as opposed to out of the garden, which is dark. It's scary. We don't know what those plants are. We don't know where the end of the garden is. We can't even see what's back there, and who knows what monsters are lurking. So let's start in the garden, and we'll work our way out. Causes of scoliosis are the garden variety, the idiopathic. And idiopathic means that we don't know what causes it. It's a medical term that just says that we don't have a clue. And this is sort of a typical garden variety scoliosis. Take my word for it, there's nothing else going on. It's bad enough, it's a bad curve, and that is one that needed to be fixed. But there is a whole other list of things that are not garden variety. And as I said, a lot of times we ignore those. And this is finally my chance to talk about some of these things. And as you can see, place of honor, the Chiari and the Syrinx, which are definite causes. I'm not going to talk about non-organic, leave that for another talk. That's things like leg length discrepancies, pain syndromes, things where you have a curve that isn't really even a scoliosis. But these are the cases, the congenital, the neuromuscular, et cetera, where there's more than meets the eye. And the important thing is determining what's garden variety and what isn't, and what might be underlying there, what might be out in those woods that we've seen. Well, having said that, I'm going to talk about adolescent idiopathic, because you got to start somewhere, and you have to have the basis of what is going on. And there's no question this is far and away the most common. 95+%, probably more like 99%. Girls outnumber boys 5 to 1. It may be more, depends. In my clinic, it's probably about 8 to 1. The incidence is quite high. It's higher than people think. It's about 2, maybe more out of 100. So there are a lot of kids with scoliosis walking around. Most of them present at about 9 to 14 years of age. That's the ages when kids tend to start their growth spurt, and that's when the screening really starts in earnest. So that's where, if you had a curve, you start to see it. Most of these curves have been in existence for a while. It's just a matter they haven't been detectable until then. Treatment is basically lumped together by mild curves, and I won't talk about Cobb angles and all that. I don't think that's the place, but we have mild curves that look pretty benign. We tend to watch them and make sure that they don't get worse. Moderate curves, where we tend to start talking about bracing. It's controversial. Not everybody uses them. I believe in it strongly. That's a talk for another day. And if it's very severe, if it gets bad enough, you have to fix it. And understand, when we fuse, when we do a surgery on the spine, we're not actually fixing the scoliosis. We're just fixing the outward manifestations. All we're doing is straightening a spine that is somehow has this curve involved. But fortunately, most scoliosis is about 1% do not need treatment. About 99% of all these garden variety do not need treatment. And most of them are pretty benign. They can create pain, they can create other problems. But with the adolescent idiopathic, we try to figure out which are the ones that are going to progress. We try to figure out which are the ones that need bracing, that might need surgery. So that's the subset, and we have to watch closely and sort of figure out what's good and what's bad in those as well. When we look at any scoliosis, I should say the etiology of idiopathic scoliosis, well, we don't know. It's idiopathic. So could it be a balance center? Could it be something in the inner ear? There are people who think that, and there are some signs that that might be related. It could be abnormalities of growth, differential growth. One side for some reason is tethered, the other side is not, and so you get a mismatch in the growth. One thing we do know is that it's genetic. We know that from studies from before, where we've seen concordance of twins. We know that if one twin has it, there's a huge chance that the other twin will have it. We know that it runs in families, so there's about a 5 or 10 times increased likelihood of a child having it if her mother has it, or if one child has it, of other people in the family having it. And we now have actually localized 53 places on the genome which are associated with scoliosis. Some people say it's 71, but the other ones are still sort of being evaluated by right now. And that actually has led to some prognostic testing. There is a test called the Scoli score where we can look at those 53 loci. We can see what pattern the child has, combine that with the curve they have, and come up with an actual score, which will tell us with a reasonable likelihood certainty that a curve will progress or won't progress. And that's been an incredible tool for us. Once we've understood that, that's important. What we don't know is what these genes do. We don't know products from it. We don't know the proteins. We don't know if there's gene therapy out there. But 10, 15 years down the line, me or someone like me may be giving this talk and saying, oh yeah, surgeons don't treat scoliosis. In the old days, we had to do fusion. Now you come and we mix up a gene cocktail and you drink it and suddenly you're straight. Those days may come, I hope so. But anyway, that's sort of the future of scoliosis. It's interesting that children presenting in early childhood, less than 7 years, have a much worse prognosis than kids from 8, 9 years on. And we're not quite sure why. Could it be more gene penetration? Could it be associated anomalies with it? Or could it be that these are actually non-garden variety? Are these ones that have to be lumped into the others? We're not quite sure. We're trying to stratify that. And unfortunately, the gene tests really haven't been much help. So how do we evaluate any scoliosis? Well, as with any disease, we take a careful history. When was it first noticed? Has it been getting worse? We look at review of systems. Are you having trouble breathing? Are you having trouble going to the bathroom? Are you having trouble with numbness, weakness, anything like that? Family history. Mother, grandmother, father, anybody in the family who has curvature of the spine. We examine the spine both standing and bending, forward bend, and we look at the side as well, because scoliosis is not just a two-dimensional problem, it's a rotational problem. So instead of being a curve side to side, it's actually rotation of the trunk. And you can also often see important clues to that when you're looking at the child, not from the back, but from the side as well. We look at the limbs, particularly proportions, situation, how the limbs stand, appearance of the limbs, are they equal in size, Is there a limb that's bigger than the others? Are they unstable? Are they asymmetric in any way, shape, or form? Because that can give us an important clue to whether or not there's some underlying cause besides the idiopathic. We look at a neurologic exam, including cranial nerves. That's the function of the head, neck, and the upper arms. And also the abdominal reflexes, which I'll come back to. But that turns out to be the most sensitive neurologic finding in patients with scoliosis. And if a curve is bad enough, we get an X-ray. Now, it's important to realize that all these things, the limb exam, the neurologic exam, those should all be completely normal in a child with scoliosis. Garden variety scoliosis is just curvature of the spine. So there is no underlying process. We've ruled out everything else, and it really is just a curvature of the spine. It's not a disease, it's just a shape. And if any of these are positive, that's when we start thinking outside the idiopathic sphere. There are red flags, and these red flags, besides some of those things that we talked about, are very important because we'll see these again and again as we get into the non-garden variety. We used to say painful scoliosis. Unfortunately, teenagers today now have back pain. They didn't used to, I guess, when I was training, because we were always told painful scoliosis is bad. Red flag, red flag. Now it'd be amazing if a child didn't have back pain, let alone scoliosis. But we still sit up and take notice. If the pain is bad enough, it's unrelenting. If it's not typical pain, we start thinking there might be something else. Any nerve symptoms at all, as little as tingling in the feet, problems with going to the bathroom, anything that might show that there's some process going that's getting in the way of normal nerve function has to be taken notice of. Skin lesions, particularly as we talk about neurofibromatosis. If you have cafe au lait spots, so birthmarks, lots of them, freckling in the axilla when kids are very young, in the underarm. If you have bumps and lumps on your skin, that may be a sign of something else. Abnormal reflexes, especially that abdominal. And the abdominal reflexes where you tickle one side and you tickle the other, the umbilicus should go to the belly button should go to the side you've tickled. If it doesn't go, then there may be something else if it doesn't go on one side. And that's a huge red flag. That's automatic MRI in my clinic. Unusual shape of the curve. Instead of being a nice, well-balanced S-shaped, you have a C shape, or you have a curve that's smaller than the other curves, or you have 3 curves instead of 2 curves. Left apex thoracic curves, interestingly, most curves go to the right. We don't know why. I asked one of my attendings one time, is it different in Australia? The answer is no. But for some reason, curves should point to the right in the upper spine. And if they point to the left, we used to be taught that was a big red flag. Now, if you're normal neurologically, a lot of times we're not as concerned about it. Although I say that with a big question mark and a big red flag. Be aware of that. And I added male gender because, curiously, a lot of the curves I've seen in my clinic that have been unusual curves that have had something else have been in boys. And those are boys who come in relatively young with really bad, severe, as we used to say in Boston, wicked curves that are rigid. And we look closely and we find Syringomyelia, or we find Chiari, or we find something else there. So that doesn't mean you have to MRI every boy who has a scoliosis, but you really have to think of them as a red flag as well. So these are the ones that we start to think, all right, there's something else here. This is not just an idiopathic. This is not garden variety. So we have our red flags. We have our exam. You ready to leave the garden? It's scary. I mean, that's a pretty scary looking world out there. But take my hand. I'll guide you. We'll do this together, shall we? The first thing, we start with a baby. That's not scary. But infantile scoliosis can be scary. And it is a totally, completely different thing than the adolescent scoliosis. Juvenile scoliosis is probably just a younger version of the adolescent. Infantile is completely different. And we don't know anything about it, except that it is associated with rib anomalies. It's associated with kidney anomalies. It can be associated with syndromes. So if we see a scoliosis like this, the very first thing we do is get ultrasounds of the kidneys, make sure that the child has the proper number and the proper design of the kidneys. I am not aware, you might be able to tell me better if there's an association with Chiari. I'm thinking now, having seen these, I probably would think about an MRI and at least rule out a Chiari in these children. The good news is almost all of these are self-limited. There's a small subset that will go on and have worsening curves, which is a big problem, as you can imagine, in a little baby. But we don't know whether this is a postural problem. Is it just because the child can't sit up, or is there truly a birth defect, or is it something in the gene code that's creating that? We don't know the genetics of infantile, so that's a big question mark, and it's definitely not in the garden. We move on to a somewhat related one, congenital scoliosis. It's funny to use the term congenital when we've talked about how everything is genetic. But what we mean by congenital scoliosis are those curves that actually have bony defects. They have abnormalities of the bone. They occur in younger children than the idiopathic, than the garden variety. There are unusual curve patterns. You often see short curves, sharp curves instead of long sweeping curves. And they're created by either failure to form or failure to segment. The bones of the spine actually are created by 3 separate areas of the growing, developing child. And they fuse together at certain times. If something blocks that fusion for whatever reason, genetic basis, some sort of a chemical imbalance, some sort of a positional thing, you're going to get abnormalities to the spine. And these also are often associated with kidney abnormalities and other organic abnormalities. So you have to look for that as well. Now, curiously, the more abnormalities you have, and if you see where the arrows point, there are things all the way up and down the spine. There's a little piece, you can just see it on the left side. And you can see up there, there's a segment there, and there's abnormalities there. Those actually do better. It seems like the deformities cancel each other out. We call that a jumble spine. It's not, it's sort of a cruel joke. But they actually do pretty well. The treatment is almost always surgical, unfortunately. You either have to eradicate the deformity or you have to fuse a small segment. But these kids generally do really well and don't seem to have long-term problems once you take care of the initial issue. And I have a cartoon of some of the deformities so you can see a little bit more. You can see a partial failure to form, the complete failure to form. You see that single piece in the middle. A unilateral bar, so you can see where they're connected. They haven't separated, and you can imagine there are growth centers on the one side. There's no growth on the other side. So as the child grows, they rotate, they get into curvature. And then you have that solid bar, which actually doesn't lead to deformity at all, except for shortening of the trunk. That's actually a very favorable thing to have if you're lucky enough to have it. If you have to choose a congenital scoliosis type, that's the one to have. So congenital scoliosis. Neuromuscular scoliosis, you can get a curvature of the spine if you have neuromuscular disorders, cerebral palsy, spinal muscular atrophy, muscular dystrophy, spina bifida, anything that is going to lead to weakness of the trunk, imbalance of the muscles. And the interesting thing is this is probably not a true abnormality of the spine. It probably is just the muscles around the spine. They tend to be more C-shaped because they're postural. What happens is the spine can't support itself, so it collapses down, and you get a curve like this rather than the S shape that, for whatever reason, the idiopathic gets. Basically, the goal for these kids is to maintain function as well as you can. And that function may be upright, but may be just sitting posture and hip stability. You got to keep the hips in place so they can sit without problems. And so we try as hard as we can not to do fusions unless we absolutely have to. We try to manage the spasticity. We try to manage the muscle imbalance either with medicines or injections. We use braces for support as long as we can. We try to stabilize the hips either with bracing or surgically. And then as a last resort, we go for surgical fusion. And this rather scary x-ray, and you see the arrow pointing to the spine, and you need to point it sometimes because it's not at all where you expect it to be. Obviously, this poor kid needed the surgery. Actually did quite well, was able to sit up and able to function fairly well. A very severely involved kid with cerebral palsy. But you can see on this, it's kind of dim, but you see where the buckle is down below, how the pelvis is tilted because of the spine. And you need to level that pelvis out so the hip doesn't dislocate. So this is clearly not garden variety, clearly not idiopathic. Connective tissue disorders, which are quite near and dear to this group, can cause scoliosis. In fact, it's the norm for them to cause scoliosis. We're talking about Marfan's, Ehlers-Danlos, connective tissue disorders, collagen vascular disorders, whatever you want to call them. The trouble with these is they may appear as garden variety. They may show up in my clinic rather than in anyone else's clinic or the neurosurgeons or neurologist clinic because they have a scoliosis. And for all the world, they may look like just normal scoliosis until you start looking at things. You start looking at their flexibility. You ask questions. They're flat-footed. Yeah, my kneecap dislocates. Yeah, my hip pops. Yeah, my wrists are very unstable, that kind of thing. I've had 3 shoulder dislocations. And then the light bulb goes off and you think, you know, the combined thing, this may very well be a connective tissue disorder. And as I've learned working with CSF, and I had this inkling before, the connection between that is, well, it may very well be a connective tissue disorder. We better rule out a Chiari as well. We better get a brainstem MRI as well as the other things. The bad thing is these really don't respond to bracing. Bracing does not work in connective tissue disorders, and they just will blow right through the braces. And so aggressive surgical treatment seems to be the order of the course. And you really have to rule out other systemic issues, especially cardiac. Obviously, the heart has to be cleared before you do anything aggressive, and also ophthalmic. Every so often you hear about a kid who had spinal surgery, who has Marfan's you don't realize, and they dislocate their lens during surgery, and they're blind when they wake up. And that can be corrected, but obviously it's something that you don't want, a situation you don't want to face. You got to know about these things beforehand. Another scary x-ray, this is a kid with Marfan syndrome. You can see the very severe scoliosis. You see the long trunk, and that's one of the clues that this child has Marfan's. You look at the side view, and you think that's his waist up in the middle, and you see, no, his waist is actually down at the bottom of the screen. That's actually a kyphosis. That's actually a curvature that has been created by the rotation. So this is a very, very serious issue that you have to be aware of, and you don't let it get to this point because obviously surgery on this or any treatment on a curve that's that severe is much, much harder than a curve that's mild. So being aware of it in advance, being aware that there is such a thing as a non-idiopathic scoliosis makes all the difference in the world. There are things that grow in spines. One of them is syringes, Syringomyelia. But there are some other things. Tumors, generally benign. Malignant tumors of the spinal cord are extremely rare and tend to be in a much, much older population than I see. Most of them are just fat collections, lipomas. But they can cause scoliosis. You can have a ridge of bone. It's the most bizarre thing that anyone has ever dreamed up, but as my son once pointed out to me, if it's bizarre, you're going to be able to find it somewhere in medicine. And what that is, it's called a diastematomyelia, say that 3 times fast, and it is actually a bone spur that is in the central canal. And you can see where that arrow points. You see that black oblong disc thing. That's a spike of bone that goes all the way down. And what happens is it splits the spinal cord. The amazing thing is it doesn't cause more problems with spinal function. But as a child grows and it starts to tether, the bone doesn't want to grow, doesn't want to put stress on the spinal cord, so you get a curvature as a result. Tethered cord syndrome, which can occur with spina bifida, meaning that the lower levels are open, but isn't always spina bifida. That also creates a problem. That's where you have scar tissue that keeps the cord tethered to the bone. As a child grows, the spinal cord actually will migrate up. Actually, the bone grows below it, but we talk about spinal cord migration. If you have tethering of the cord and it's scarred down and you start to grow, you're going to pull on that spinal cord and the spinal nerves are going to stop functioning. So what do? You create a curvature. And that is how these secondarily cause scoliosis. The important thing is to see that they're there so you can decompress them before spinal treatment, before you talk about surgery. And as interestingly, with the diastematomyelia or a tethered cord, and sometimes with the tumors, you take those out. I don't take them out, neurosurgeons take them out. The patients do better, and a lot of times the scoliosis goes away. So it's a non-fusion cure for a scoliosis. It's one of the few that we have. But you have to be aware that it's there. Now, fortunately, although there are subtle findings, there are almost always findings. there's almost always a sensory difference. There's almost always the abdominal reflex difference that will just sort of let you know that that's there. And you see that and you say, okay, I better get an MRI, and there it is. But it's sort of a feel thing. It's sort of an experience thing. But you got to think that there may be something in the canal before you get in there and start doing anything, whether it's bracing or surgery. Neurofibromatosis is probably the scariest of the intrinsic lesions. That is a tumor that grows of the nerves. It's actually the sheath of the nerves, and it creates these large bulbous tumors around the nerves and horrible malformations of the nerves. It's also associated with rib abnormalities, with abnormalities of the bony shape. So you not only have abnormalities of an intrinsic lesion that's leading to that curvature, you actually have the bones scalloped out. You have the bones misshapen because those tumors are pushing on them. You also have overgrowth of limbs. You can have the cafe au lait spots that I talked about. You can have subcuticular nodules. There's a whole raft of terrible things that neurofibromatosis can have. And unfortunately, there's 85% plus involvement of the spine. Some people think it's 100%. You have neurofibromatosis, you just wait for the scoliosis to occur. What you really have to be careful are these dumbbell lesions, another terrible thing to call them. But the reason they're called dumbbell is there's a tumor on one side and a tumor on the other, and they sort of push through the neuroforamen. And so not only are they creating pressure inside the curve, they're also creating pressure outside. And so it's a double whammy. It's creating curve from both sides. And if you don't know that they're in there, and this is not a subtle finding, you'll know if a child has neurofibromatosis or an adult has neurofibromatosis. But if you don't know they're in there and you try to do anything with this spine, this child is going to have real problems. So you need to be aware that such things exist, that there's more in heaven and earth, the ratio. And now we get to the place of honor, and that's the Chiari malformation. And this is really just the culmination of everything I've taught you, that there is a high association of scoliosis with Chiari malformation. We don't really know what that incidence is, largely because we don't really know how many Chiari people there are in the world. We have a sense of people who are reported, but there are tons of them. It's been interesting since I've been involved with the CSF. I've been looking for Chiari much more frequently, and unfortunately I've been finding it. So it is there, and it's there when you don't even expect it to be there. So a lot of these kids with scoliosis that may look like garden variety, except with subtle differences, may have this. Now the etiology of this is not clear. Is it, unfortunately, that they just have the garden variety and they have the Chiari and there's a combination? That's possible. I mean, there certainly is a statistical likelihood that kids with Chiari will have scoliosis as well. And it's just that they grow uncontrolled because of neuromuscular control that can arise from the Chiari malformation or from the syringes. That's possible. Could there be anchoring of the cord by the brainstem herniation? That's what I kind of think it might be. That because the brainstem is settled in, as you're growing, that's putting pressure on it. And again, just like the tethered cord, it's just a tether at the other end. You don't want to put pressure on it, so you try to relax the pressure, decompress it, if you will, by doing the curvature. And then it gets fixed in the bone. I think that that's a possibility. I think it would be hard to prove. No question that that's where the Syringomyelia creates scoliosis as well. Could there be some sort of intrinsic developmental abnormality of the vertebra that's close? I don't know if there's theories about the brain case, that it's too small, I know that there's theories that the foramen magnum is too small, and that's one of the reasons why the Chiari occurs. So could there be some malformation of the spine? That's certainly a possibility as well. Obviously, it's something that research will show us. Obviously, the overlap with connective tissue disorders and syndromes is really important too, because we know that they're related to Chiari. We know that they're related to scoliosis. So what is it, the transitive principle? It's been a long time since I did geometry, is that? You therefore have the association between Chiari and scoliosis. I think this opens more questions than it's worth, but the curious thing is, and the reason I got involved with the CSF, is every year I would see 3 or 4 kids showing up with scoliosis who were not typical, had abnormalities, and those kids had Chiari. So that association is there. I can point to large numbers, relatively large numbers in my population who have it, but you have to be aware that it's there. Why do you have to be aware? Well, for one thing, scoliosis may be more aggressive. So the curves in Chiari are more aggressive than garden variety. There also may be unusual patterns. These are those left apex thoracic curves that we talked about. They're the ones who might have the Chiari. Triple majors, so 3 instead of 2, abnormal shapes. And the other thing is that bracing may not be as effective because these are very aggressive curves. Now we're back to our young lady. This is a young lady, very young, with that mild left thoracic curve that I showed you way back when. Well, okay, equivocal, and I will tell you, I did not see her at this point. Equivocal, I mean, it's not much of a neuro exam. She's fine, little curve, left apex, but we don't have to worry about that. She came into my clinic about 10 years later, and that was her. And, you know, rapid progression, severe curve, brain stem, brain MRI, large Chiari malformation, had a decompression followed by surgical treatment. So I'm not throwing stones at this doctor at all, but I am saying that's the classic example. Left thoracic, it's a red flag. It's a red flag for a reason. So you need to be aware that that's there. Again, the importance of the diagnosis. You've got to take care of the Chiari. You have to take care of the syrinx before you take care of the scoliosis. The scoliosis is there. It'll be there when you're done. Don't worry about it. The worst that can happen is they'll go to a center and one of the doctors in the center will take over the scoliosis and you'll lose the surgery. It's okay. But the important thing is that the malformation and a syrinx, whatever's in that canal, whatever is causing the problems has to be taken care of first. And curiously, as we talked about, the neurosurgical treatment may actually be curative. I've seen kids, very young kids, with curves that look like they were heading to surgery, who had a Chiari malformation, who had decompression, and the curve straightened up. And cost me a surgery, and I was as happy as their parents. I hope you believe me when I say that. So it is important to give that a try, but to make sure that the coast is clear and make sure that everything is fine before you get on to taking care of the scoliosis. Other clinical importance, as I said, the patency of the spine, the openness of the spine has to be treated before you do anything aggressive orthopedically. There are documented cases of neurologic damage from scoliosis fusion during surgery because nobody looked to see if there was a Chiari malformation. You're in there, the evoked potentials, the spinal monitoring gets bad. And you let go of the fusion and they're fine, and you do it again and it gets bad again, so you back off. And then you do the MRI and you find that there was a Chiari malformation. And there are paralyses that are reported as well, fortunately very rare. You got to know that it's there. You have to know that there's a possibility of nerve problems even from bracing in this setting, because there may be a reason why the body wants to be that. And if you straighten it with a brace, you're now tugging on the brainstem, you can create neurologic problems. And I have seen a child go in the brace, lose bowel and bladder control. We got her out of the brace pretty quickly, everything was fine, and then we went and made sure that the brainstem was okay, and it wasn't, it was a Chiari. And so we backed off and then came back and did the scoliosis treatment later. I throw in the risk of chiropractic manipulation in the face of an intrinsic spinal cord. The chiropractors, who I don't want to start any argument, I'm actually not opposed to chiropractic care. I think that they complement our care very well, but they're not the ones who are going to diagnose a Chiari malformation. They're not the ones who are going to find these things. It's up to us. It's up to the pediatric people. It's up to the parents to say, could this be something besides the idiopathic scoliosis? And the other impact on clinical course, we talked about the worsened prognosis of progression. The pain profile may be completely different in a child with Chiari. If you do a scoliosis fusion, what you would expect in terms of pain may be completely different from the next kid along the way. There may be atypical symptoms. The pain may not be in the back. It may be in the leg because you've decompressed. There may be a longer time before the child can get to the bathroom on her own. And you need to be aware of that so you can counsel the parents, you can be ready for it if you need to step in and do something. And the other thing that's scary is the awareness of signs of recurrence. If I'm seeing a child in the clinic and I know that she has Chiari malformation and she's had a spinal fusion and she tells me, I'm doing really well, but you know what? My big toe has been really numb for the last week or so, and it's getting worse. I am going to send her to the neurosurgeon, or I'm going to do an MRI because of the possibility that there's pressure in there. And that's not something that you would do with just the garden variety idiopathic type. So really, it's just awareness. It's just knowing that that's there, and it really makes everything safer. We lose some of the control just because it is a problem, but you need to know that that's there. So the take-home message, vast majority of scoliosis is garden variety. Don't worry about it. It really is idiopathic, but be aware of the red flags. If you know your child, or when you go to the doctor, you know that there are red flags there, let the doctor know that. Let them know that they have trouble going to the bathroom. Let them know that there's been some tingling in their legs or big toe problems or something. If the curve is suspicious in terms of any of these things, progression, shape, symptomatology, you've got to have a low threshold for imaging and send them to neurology or neurosurgery. It's not a time to be brave. And the big thing is, before you do anything aggressive, before I would do surgery or you allow any doctor to do it, look before you leap. Make sure that the coast is clear. And consider Chiari, because it's obviously there. So, thank you. Are there questions? Covered a lot of ground. Yes, sir. The question is, what do I think the indications for the decompression surgery is? And I'm not really qualified to do that. I'm not a neurosurgeon, so I don't do the decompression surgery. But I certainly would refer a child to neurosurgery to at least have that evaluated if there was a big curve, if there was pain that was atypical, if there were neurologic findings, anything where there seemed to be compression on the neural elements, and if it looked like something that was worsening with time. I think that's an oversimplification. I'm sure there's a better answer to that question, but that's the orthopedist's very simple approach to it. Sure. The question is, well, the first statement is that, that there may be a difference in terms of bracing effectiveness in kids who have had decompression and those who have not had decompression, because of my point that in Chiari the bracing is not as effective. And do I have experience? To be honest, no. The interesting thing is, with the decompression, it's either clean cure of the scoliosis, interestingly. So they go from a 45, 50, 60 degree curve to a 20 degree curve and don't need bracing, or it's a 60 degree curve and they don't change at all. So I haven't really had any patients that have said, oh, you know, you're a little bit better, let's try the brace now. My suspicion is it probably would not change, because I think there are intrinsic problems with the scoliosis and the tissues rather than the pressure on the brainstem. But I don't have any basis for that except my own opinion. So it's an excellent question. I just don't think the numbers are there to make a definitive answer.
Why do some people the rib hump collapses and some people it does not?
That's a very good question. Why does the rib hump, why is it correctable in some and not correctable in others? In the big curves, you reach a point where you just can't derotate. You can't bring it back anymore because you run into the ribs on the other side. And it's not, early on, it's not, it may just be that the curve is rotated, but if you actually look at the CT scans and you actually do the anthropometrics on the ribs, they are abnormally shaped by the time you reach a certain age or a certain level of maturity. And it's not as old as you would think, unfortunately.
So even at 12 and a half?
So even at 12 and a half, the thinking is that the chest stops remodeling as early as about 9 or 10 years, probably much earlier than that. And then you start to have the forces working against. And remember, her curve was there for a lot longer before. So they derotate as much as they can, but unfortunately the rib prominence, the actual rib deformity, I hate to use that word, is there. and it's fixed in the bone. And so you can't change that simply by manipulating the spine. CT scans before surgery can sometimes clue you in, but they're not very helpful in terms of being able to correct it. So much radiation, I don't usually do them myself. So, so the question is, did you do thoracoplasty? It doesn't sound like you did. That's where they shave down the ribs?
No.
No. It can help. Thoracoplasty can help, but interestingly, in the United States, people don't do a lot. They sort of poo-poo it. The literature says it works really well, and there actually is some literature to suggest you can do it without fusion. That if you have a curve that's fairly moderate and you have a big rib prominence, you do the thoracoplasty, you take off the ribs, and it corrects the deformity without changing the spinal fusion. But that's not considered sort of standard of care. There's no such thing as standard of care, but that's not really considered a typical course in the United States for whatever reason.
But you would do that during the actual spinal fusion surgery?
No, you could do it after.
So you're talking about removing the rib?
Yeah, it's still possible. It's a big time operation.
Because she would like to someday.
Okay, well,
But
it's doable. It's just it is cosmetic. Although not always strictly cosmetic, and it is something can be done. You want to balance it. You want to wait until you're sure you're fully mature, sure you're fully grown, make the decision yourself. You don't want to wait until you're so old, because you do get into the chest to do that, and so it does have some issues with that. But it is a very viable operation, and the literature says it's really good. It's just people say, oh, no, you can't cut the ribs. We've got this wonderful mechanical ability to correct it, and they don't. We don't.
But you don't recommend it?
I don't do very much of it.
It's okay.
Let's put it that way.
Yeah. I would like her not to have it.
Yeah. But yeah, I mean, it's one of those things, just like the scoliosis surgery, to go in with your eyes wide open, because the recovery is probably worse than the scoliosis surgery. Especially, not the least of which, because you're going to be older and your spine's going to be much stiffer because it's been fused for this long. But it is doable, so consider.
And I can offer my completely non-medical 2 cents worth on it. It was
I'm sorry, I didn't understand the question. Sorry.
I mean, the fusion strategy.
Oh, in terms of my treatment strategy, is there a difference between the garden variety, the AIS, and Chiari? The only difference, as I said, is to make sure that it doesn't need a decompression, and to understand that bracing may not work. But in terms of the surgical treatment, no difference. I will probably be a little bit less aggressive about reduction of the rotation and more about distraction, because part of the surgery is the distraction of the segments. So scoliosis correction is not just derotation. You actually distract through the concavity of the curve. And you don't want to distract too much if there's a possibility of some sort of tethering, and also the possibility that there might be a syrinx that just wasn't picked up on an MRI. I mean, that's possible, not very likely. So I'll be a little more cautious about the correction. I won't go for a home run, if you will. I won't go for 0 degrees. I'll try to do a balanced curve, but maybe leave a little more curve than I would without that. So, the point is that there are papers that suggest that the correction loss is higher. So in other words, that the curves can recur more in patients with Chiari than the idiopathic. And yeah, no question. I don't have a big enough series of the Chiari corrections to be able to say, yeah, it's this percent in mine and that percent in the other, so I don't have really a personal anything to offer in terms of my personal data. But yeah, I am aware of that. It's certainly something to think about. But it may also be just because of the other tissues and because the area where you don't fuse are not going to be normal in a Chiari as well. So you could actually have either extension of the curve or something above and below the fusion. And that may be a factor in allowing the worsening of the curve.
We're going to go ahead and wrap up. Thank you, Dr. Keith Mankin.